Sayın Mütevelli Eğitim Başkan Yardımcımız, Sayın Provostum, Sayın Dekanlarımız, öğretim üyelerimiz, öğrencilerimiz ve çok değerli onur konuğumuz Bahçeşehir Üniversitesi Tıp Fakültesi'nin 7. Bilim Nişanı Takdim Töreni'ne hepiniz hoş geldiniz. Törenimiz bildiğiniz gibi Profesör Doktor Peter McLaren Black onuruna düzenlenmiştir. Hem İngilizce hem Türkçe sürdüreceğiz törenimizi. Sanıyorum pek yabancılık çeken olmayacaktır bu duruma. Mr. Provost, Deans, faculty members, students, guests, and of course, Professor Black, welcome to the 7th Annual BAU School of Medicine Outstanding Scientific Achievement Award Ceremony. We're here today in honor of Professor Black. Şimdi müzik eşliğinde Dr. Black'ın hayatından kesitler izleyeceğiz. Bize eşlik edecek olan çok değerli sanatçılarımız Verda Ferah ve Ayça İşçen'i sahneye davet ediyorum. Now please sit back and enjoy a musical performance and our slideshow featuring Dr. Black. Bahçeşehir Üniversitesi Provost ve Rektör Yardımcısı Profesör Doktor Ali Güngör'ü konuşmalarını yapmak üzere sahneye davet ediyorum.
Good afternoon, everybody. Dear guests, welcome to this 7th Annual Outstanding Achievement in Science Award Ceremony, today in honor of Professor Peter Black. Professor Black, welcome to Bahçeşehir University. We are delighted to have you back, as well as we all celebrate your contribution to science. I was pleasantly surprised to find out that we may have crossed paths at Georgetown University back in the 70s. The award you will receive today is granted to distinguished scholars and scientists by our medical schools and hosted by Bahçeşehir University. Thank you for coming. The most important priority of a university is teaching students to be curious about the world and make it a better place for everyone through learning and advancement in science. This is not possible without outstanding role models to inspire and guide students. Therefore, it is crucially important that our students and faculty members are able to meet individuals such as Dr. Black, who have the qualities necessary to motivate science excellence and set high standards. Indeed, it was his artistic background, doctorate in philosophy, medical and surgical experience, as well as his work in the laboratory. Dr. Black is a stellar example of the high standards we hope our medical students will one day achieve. On this occasion, I must congratulate our medical faculty and Dean Türker College for nominating you. Your commitment to raising doctors and scientists for the coming generation is commendable. I hope the time you are spending with our students and faculty members has been fruitful and will inspire them to greatness. As a fellow scientist myself, I am also looking forward to hearing about the lessons you have learned and hope everyone in this room will look at the world in the different light as a result. We must all remember that we can all learn a lot from each other. This is the main intention of science and gatherings such as today. As the Provost of Bahçeşehir University, I welcome you once again to Istanbul and to our university, and I congratulate you for your accomplishment, Professor Black. Thank you.
Sayın Provost'umuza çok teşekkür ediyoruz. Thank you, Mr. Provost. Şimdi sahneye Bahçeşehir Üniversitesi Tıp Fakültesi Dekanı Sayın Profesör Doktor Türker Kılıç'ı sahnelerini bekliyoruz.
2015 Bolu Tıp Bilim Madalyası sahibi sevgili hocam Necmettin Pamir, Türk Nöroşirurji Derneği Başkanı Savaş Ceylan, çok kıymetli mütevelli heyeti Başkan Yardımcımız Coşkun Bey, çok kıymetli dekan yardımcılarımız, sevgili dekan arkadaşlarım, sevgili hocalarım, sevgili öğretim üyelerimiz ve en önemlisi çok sevgili öğrencilerimiz. Bugün hocam, dünyanın önde gelen bilim insanlarından Profesör Doktor Peter Black için buradayız. Ben bazen bilimsel sunumları yaparken aklımı daha önde kullanmam gerektiğinde İngilizce konuşmayı tercih ediyorum ama gönülden yapmak istediğim konuşmalarda Türkçeyi kullanmayı haliyle yeğliyorum. O yüzden Meltem dediğimi hocama çevirecek. Şimdi bu slaytta gördüğünüz gibi ilk günden beri kullandığımız, bizim tıp fakültemizi anlatmada kullandığımız cümle, İyilerin Bilim Tıp Okulu. Ne demek istiyoruz burada? İyilerin Bilim Tıp Okulu'nu esasında kendi bünyesinde canlı hale getiren bir rol modeli Peter Black. Burada anlatılmaya çalışılan 4 özellik var. Birincisi, biz sadece iyi bir hekim yetiştirmeye çalışmıyoruz. İyi bir bilim insanı hekim yetiştirmeye çalışıyoruz. İkincisi, buradaki tırnak içinde iyi derken kastettiğimiz hem mesleğinde iyi hem de iyi insan. Dolayısıyla burada bu 3 kelimeyle anlatmaya çalıştığımız 4 önemli kavram var. Ve bu 4 önemli kavramı hocam kendi bünyesinde yaşayarak bize gösteriyor. Dolayısıyla bu sene Peter Black'i bu yılki madalya sahibi olarak seçmemizin ve öğrencilerimize rol model olarak takdim etmemizin en önemli sebebi bu. Birincisi, kendisi çok iyi bir hekim, hastasına çok önem veren ve onun için gerekli empatiyi gerçekten gösteren iyi bir hoca, iyi bir öğretmen, iyi bir klinisyen. Dolayısıyla Bilim Tıp Okulu'ndaki tıbbı iyi örneklenmesi açısından bu önemli. Bu birincisi. İkincisi, işin bilim kısmı. Peter Black çok önemli bir bilim insanı. Sadece cerrahi alanda değil, nöroşirurjinin bilim kısmını gerçekleştirmekte ya da bunun temel bilimlerle bağlantısını kurma açısından da çok önemli rol oynuyor. 2 önemli buluşu var. Bunlardan birincisi ameliyathane MR'ının dünyaya tanıtılması ve bunun keşfindeki katkıları. İkincisi de benim gözümde moleküler nöroşirurjiyi tüm genç beyin cerrahlarına bir hedef olarak göstermesi. Bu iyideki mesleğinde iyi olmanın ilk iyisi buradan kaynaklanıyor. Yani işini iyi yapıyor. Ve bu nedenle de önemli başarılara imza attı. Kendisi lisedeyken piyano çalmayı öğrenmiş. Daha sonra felsefe eğitimi almış. Daha sonra Harvard'da beyin cerrahisi, uzun yıllar Harvard'ın daha sonra Dünya Beyin Cerrahisi'nin yöneticiliğini yapmış. Ameliyathane MR'ını keşfetmiş. Moleküler nöroşirurjiye adım atmış. Yani bir insan 400 tane makalesi var. Dolayısıyla bilimsellik açısından fazla diyecek bir şey yok. Ama bizim burada esas rol modeli olarak kendisini göstermemizin, öğrencilerimize göstermemizin diğer çok önemli bir sebebi daha var. Kendisi iyi bir insan. Ve bizim artık önemli vurguladığımız şeylerden biri şu, var olan kültür yerini yeni bir kültüre bırakıyor ve bu yeni kültürde eskiden önemli olan zeki ve çalışkan olmak yerini iyi ve yaratıcı olmaya bırakıyor. Ve iyi ve yaratıcı olmanın çok güzel vücut bulmuş bir kimliği Peter Black. Bu iyi insan olmak derken kastettiğimiz şey esasında basit. Bulduğundan daha iyi bir dünyayı sonrakilere devretme isteği. Ve bunun için de gerektiğinde terlemekten çekinmemek. Kendisi bulduğundan daha iyi, bulduğundan daha gelişmiş bir nöroşirurjiyi gelecek nesillere bıraktı. Bu kesin. Ama bulduğundan daha güzel bir dünyayı da gelecek nesillere bırakıyor. Kendisinin son 3 günde çok kıymetli öğrencilerimle geçirdiği zamanlar öğrencilerim açısından gerçekten herhalde unutulmaz anlardı. Bulduğundan daha iyisini bırakmak bizim tıp fakültemizin en önemli şiarlarından biri. Dolayısıyla biz inanıyoruz ki iyi olmak başarılı olmaktan daha önemli. Bu nedenle ben hocama burada olduğu için ve bu madalyayı kabul ettiği için bir kez daha teşekkür ediyorum.
Sayın Dekanımıza çok teşekkür ediyoruz bu konuşmalarından ötürü. Şimdi törenimize geçeceğiz. Dolayısıyla sahneye öncelikle Sayın Provost ve Rektör Yardımcımız Profesör Doktor Ali Güngör'ü, dekanımızı Profesör Doktor Türker Kılıç'ı, dekan yardımcılarımızı ve bölüm başkanlarımızı, değerli hocalarımı takdim masasına buyurun sahneye davet ediyorum. Sayın Mütevelliyet Başkan Yardımcımız Coşkun İnce de bize katıldılar. Buyurun hocam. Şimdi izninizle Doktor Black'in özgeçmişini sizlere İngilizce olarak sunacağım. Değerli hocalarım. Born in Canada, Dr. Peter Black became an associate of the Royal Conservatory of Toronto as a solo performer in piano while he was in high school. He attended Harvard College, graduated with honors, and returned to Canada for medical school at McGill University. He entered surgical and then neurosurgical residency at the Massachusetts General Hospital. During this period, he served 2 years in the U.S. Navy, mostly at the U.S. Capitol, as a physician to Congress and the Supreme Court. He earned a PhD in philosophy from Georgetown University. In 1980, he joined the staff at the MGH, and in 1987, he became the founding chair of the Department of Neurosurgery at the Brigham and Women's Hospital. He also chaired the Department of Neurosurgery at Children's Hospital in Boston, and is currently Chief Emeritus of Neurosurgical Oncology at the Dana-Farber Cancer Institute, and Frank Ingram, Professor of Neurosurgery Emeritus at Harvard Medical School. A highly respected clinical neurosurgeon with many international patients, the professor was consistently listed in Best Doctors in America and Top Doctors. His special interest areas are meningiomas, pituitary adenomas, and low-grade gliomas, image-guided minimally invasive neurosurgery, skull-based surgery, and brain mapping. Dr. Black helped to develop the first intraoperative MRI and has used this device extensively to improve brain tumor treatment. He has also extensive experience in epilepsy surgery in children and hydrocephalus in adults. The former president of the World Federation of Neurosurgical Societies, Dr. Black has a very large bibliography, including 10 books and 500 papers, most of which involve brain tumor management, brain imaging, image-guided surgery, medical ethics, and molecular neurosurgery. Dr. Black is deeply committed to neurosurgical education around the world. He has mentored students, residents, young faculty, and graduate neurosurgeons from more than 30 countries and has given invited lectures in 40. He is very proud of the productivity of his former trainees, many holding prominent academic positions. And we are honored to have him here today. Sayın konuklar, onur konuğumuzu sahneye alırken tüm misafirlerimizi, sizleri ayağa kalkmaya davet ediyoruz. To receive the BAU Award, please, Professor Black, would you come to the stage? Dr. Black will make a speech.
thank you very much for this wonderful honor and for the opportunity to be at Tip and meet some of the wonderful students that are part of this great medical school. I want to particularly thank Dean Kilich in Burbank and the Tip faculty, the provost, previous recipients, and our faculty here today. And especially to the class that began in 2015 at Tip, many of whom I've met over the last few days and had an absolutely wonderful time talking to about their lives and hopes and aspirations. This is such a great honor to be able to be the patron of a class as well as this concept of receiving the medal. I want to just spend a couple of minutes talking about the research that I did and how I got there, because I do believe that research comes out of a need for doing good patient care. That is, I think it's not that there's research on this side and there's being a doctor on the other side. I think if you're a thoughtful doctor, you understand that there are tremendous areas that need to be improved, and there should be a need to try to help improve those. And so that's how I got into the whole field of brain imaging and better brain surgery. And the concept was to use brain imaging to do safer and better surgery. So we developed, through the surgical planning laboratory at the Brigham, a way of looking at tracts and of tumors and of the mass effect of these tumors on the brain. And we're able to show, for example, here's swelling around a tumor with a tumor, what happens to the various tracts around it. And maybe we could make the lights a little bit lower, if you don't mind, so we can see these slides better. So here, for example, is a tumor in the motor area. And the point about this mass is that it distorts the fibers of movement that come from here. But if you can get through this little sulcus, the normal sulcus in the brain, you can actually take this out safely. And we do that with the patient awake, so we know that we're not hurting the movement as we do it. And the result is that you can do miraculous surgery. That is surgery that 20 years ago would have been thought to be absolutely impossible. We're able to do virtual reality back 20 years ago, and I show this slide because it demonstrates what medical students can be as scientists. This is actually a person who worked in my laboratory, a young woman. This picture of the so-called patient we're doing of her brain. She is now a very happy academic doctor. She decided from her experience to go into medicine and also continues to be a good friend. And she allowed us to be able to use her brain to sort out how you could find where something is in the brain very easily in a living person. So this is her real head. This is the picture of her brain. And we could then put three-dimensional goggles, even in 1997, and be able to work in that space, although we never did surgery on her. I'll demonstrate an example of what we now can do using the combination of imaging and electrophysiological testing. So this is a kind of patient who used to be inoperable. It's a young man who has intractable seizures because of this tumor that's in the left frontal area. It's right in the speech area. This is the movement area of the brain. You see this pink line is the motor cortex that we've been able to define, as I'll show you in a minute. And the problem is, can you take this kind of tumor out? And what we do in this kind of setting is to, first of all, put on a grid over the surface of the brain and then close the head up so that we can test with the grid exactly what function is where. And we can do this to do movement testing, speech testing, vision testing, any kind of physiological test we can do. And what we found here is that you can see that the speech area was directly over the tumor. So speech is here. The seizure focus was in more or less the same place. So the problem was, how do you get at this tumor, which was a low-grade glioma, a more or less benign tumor, at least a tumor that itself would not kill the patient, but the seizures were devastating to this young man. And what we can do to be able to remove this tumor is to do surgery with testing at the time of surgery to make sure that we're correct in what we think is the movement and speech area, and then to map out where these are. So here we have speech and here movement. That is, this is speech, this is movement. And then we can sneak in behind the movement area, as you see here, through a sulcus of the brain. So through an actual physiological sulcus can sneak under, because the tumor is under the brain. If you look at that brain surface, you can't tell that there's tumor there. But we know that it's there because of the imaging, and we know that we can't damage the brain of this surface because that's a speech area. And the result is that one can undercut this. We do the surgery with the patient awake, so we know we're not hurting his speech. And the result is a postoperative MRI that shows what looks like the removal of his speech area. That is this, if you looked at this, you'd say, well, there's no way that man could talk. But in fact, because the tumor displaces the normal fibers, which we can show, and because we can find a way of getting at it that is safe, we can end up doing this kind of surgery safely. We developed as well, and this again has to do with Ron Kinkinis and Frank Yolis and the Surgical Planning Laboratory at the Brigham, a navigation system which has been very important in being able to do this kind of navigation. But we found that one of the problems was that if you started, it's something like trying to navigate with a GPS system in downtown Istanbul right now. That is, a GPS, if it's not right up to date, shows you to go, it tells you to go one way, but the problem is that that road is blocked off because they're doing construction or because the police has blocked it. And so everything shifts, and this happens in the brain as well. So if you look here, this is an MRI of a brain during surgery. So you're actually looking at an intraoperative image here. And you see the tumor in this area. You see that we've taken off the bone on the surface of the brain. But as you'd expect, as we remove the tumor, the brain falls in. The brain falls, so the old landmarks no longer are useful. And that, in a word, is what led us to realize you had to repeat the image during the surgery. And so that's how we came to the idea of doing MRI imaging actually during operations. And this came, in other words, out of a need to provide better patient care. And it just turned out that I was lucky enough to be in a hospital where the radiologist, Frank Yolis, was interested in this same problem from the point of view of imaging. And so with his interest, and with Ron Kinkinis from the Surgical Planning Lab, we were able to develop the world's first intraoperative MR that you see here. It's now out of commission, but it had an area here that you could actually operate within the magnet, and that leads to some things that I'll show you in a minute, which can't be done with normal present intraoperative images, more or less. But it's very much a team effort. It's very much an effort that requires nursing, as you can see here, nurses, engineers, radiologists, anesthetists, surgeons, and techs. It's very much a team initiative, and that's the model for medicine today. The idea of the surgeon as being the person who just runs the operating room and everybody has to bow down to that person is gone. The surgeon is a team leader, but it's a team effort. And so we could show things. This is a picture that is a little bit unusual, but you can see here's the place where the tumor has been, the skull has been opened. Here's the tumor, and what's the gray shadow? Anybody got an idea? That's my hand, right? Those are my fingers in the MRI. Before we could do the navigation that we wanted. So I wanted to know exactly where the back wall of this tumor was. And with this device, which allows you to do surgery concurrently while you're doing the imaging, you could get this kind of picture. Or a picture of the next one, which is the transsphenoidal surgery, where we're taking a tumor out. This is a tumor which is pressing on the optic nerve. Here's the speculum through the nose that lets us do this surgery, and we can then take it out and see exactly what we've done. with imaging during surgery. And the present systems don't allow quite this sort of intraoperative manipulation in the magnet, which the previous one did. But the problem is that the old GE system was too clumsy to use worldwide. So the systems that are now present in many places in Istanbul, including here, are slightly different in their concept. And I'll show you the sort of thing that one can then do with intraoperative imaging, which is really, again, quite miraculous. So this is a young woman who came from outside the country, and she had this mass, and I hope you can see this little whitish mass of very benign glioma that is not a normal low-grade glioma, but it turned out to be curable by surgery. But the problem is getting to it, because it's right in the movement area of the brain. So when we did all the mapping, we realized that this thing was sitting right in the movement area. So the question is, how do you then safely know where it is? Because your eyes and your fingers don't tell you exactly that this is tumor and not brain. But with these kinds of techniques, you can first of all make a small incision, which is not a big deal, but it does mean that the healing is quick. Here she is in the operating room with her face down. Here's the place where we've taken off the bone. And what we're going to do is to come along the falx, the middle part of the brain, to this area, and then use that slicer that I showed you, that navigation system, to know exactly where that mass is, because my eyes and my fingers don't tell. And doing that, we can then remove the tumor that you see here and close up, and everything should be fine. And it was. This was a woman who had, again, been debilitated by seizures, and everyone had said that it was impossible to remove this. But with the intraoperative imaging and the preoperative physiology, we could remove it. And this is, you'll have to tell me which is the patient, because this is her twin sister who came with her. And this is a few days after the surgery. And she's been seizure-free since then. This is, for those of you who are interested in epilepsy, this is lesional epilepsy surgery, essentially. And if you take out the mass, then the seizures go away, and this is what happened with her. So we did about 1,000 cases in the intraoperative MRI, and about half of them were low-grade tumors, which are really remarkably improved by taking them out in this setting. And this is some data that we were able to show, and Professor Pamir has shown as well, that this kind of surgery makes a significant difference in the life of a patient. So in this case, this is the odds ratio. If you can get all the tumor out, this is the chances of surviving versus not getting it out. So there's a 17.6 times higher chance that you're alive if you have this kind of surgery, if you have a low-grade glioma. 17.6 greater chance that you'll be alive at 5 years than if you don't have it. So it's a significant contribution. Back in 2011, the leaders at that time in intraoperative MRI met at one of the early conferences of intraoperative imaging. And the interesting thing for those of you who are medical students, all of these are surgeons who developed intraoperative imaging with radiologists, but in different ways. So Rudolf Falbush, who worked with Siemens, just created the Siemens system here. Professor Pamir did a very early kind of way of showing that you could do intraoperative imaging with the Siemens system. These folks did other kinds of systems that have all been very important in the development of intraoperative imaging. This is Frank Yoles, who unfortunately died a couple of years ago, who was really the brains behind the whole concept of doing, being able to create magnets that allow this to be done. And now there are a lot of intraoperative installations around the world, including here in Istanbul. You can see the number of them. The other thing that this ends up being is very important from the point of view of collaboration, of understanding brain function, because it involves imaging the brain and understanding what part of the brain does what kind of function to allow safe surgery. It also can lead to other disruptive technologies, and I'll just point out 3 of them here. One of them is interstitial laser therapy. So you might say, well, if you're going to destroy something deep in the brain, can you do it without having to go through brain tissue with a big opening? And the answer is yes. You can use a laser fiber, and you can watch the heating of the laser fiber in under MRI. And so in this case, this is something called a hypothalamic glioma, which is again a low-grade tumor in a very bad place. And one can put a laser fiber, which you see here. This is the fiber going into the glioma. These are not great images because they were done in the early 0.5 Tesla magnet. I think Dr. Kilichu has this kind of system, and Dr. Premier could show you much better pictures, but the concept is the same. And you can destroy that with heating. That is just by heating it and keep the patient safe. A second kind of therapy that I think you'll hear about more and more in the future, especially for functional neurosurgery, is what's called focus ultrasound. And the idea of this is the same as if you take a magnifying glass and take the sun's rays and burn a stick. The focused ultrasound does that with ultrasound, with microwaves. And so you can destroy a target in the center of the brain without ever opening the brain. And that's what we have shown here in animals. And then again in humans we were able to show that you could do this. But look at the team that's required to do that. And then finally, at the Brigham now, the Amigo suite, that is a suite that combines intraoperative MRI with PET scan with angiography. And so it becomes a minimally invasive laboratory. And the person who runs this, I'm pleased to say, is a woman who's a full professor of neurosurgery at Harvard Medical School, who is a remarkable mother of 2 children, a remarkable woman demonstrating what women can do in neurosurgery, and who's making great advances using this device, which brings all imaging modalities together. That's Professor Alexander Golby. And also is using mass spectrometry to be able to look at the tissue that's taken out while they're doing the MRI with another young woman named Natalie Agar. So the whole imaging and image-guided and intraoperative MRI initiative arose out of the need to provide better surgery for patients. And that was probably 60% of my scientific work. It's engineering, it's imaging, it's not molecular biology, but I also did because I also wanted to understand these tumors better. We also had a molecular genetics lab, and do believe that molecular neurosurgery is very important. This was a lab that was run by a woman named Rona Carroll, and I think it's important for doctors who are going to do science to recognize the central need to have scientists who are full-time scientists work, I think, in the lab with you as well. And the idea was to improve the understanding and therapy of malignant tumors, and this was the lab at one point in its life. And here's an example of one of the things we tried to do. We showed that using anti-angiogenic agents into a tumor could make the shrinkage of the tumor much more than systemic chemotherapy. In this case, this cute little mouse that's sitting in my hand is the mouse that has the tumor, and this is the difference. This is with systemic chemotherapy. You can see that the tumor is still pretty big after a period of time. In fact, the animal had to be sacrificed after this. This is putting a small micropump to put the anti-angiogenic, the small molecules that stop angiogenesis in the tumor, and you can see there's a very significant difference. So this is the kind of work that the laboratory did to try to find targets for better therapy, or for meningiomas, trying to identify meningiomas that would need more aggressive treatment like radiosurgery by the molecular biology. And I had the great honor of writing a textbook with Professor Premier on meningiomas. So I want to just, so that's it in the science. I did want, because Professor Kilic asked me to do this, to leave you with 3 kind of concepts that I think after my years of medical and scientific work that I think are important. And there are 3 lessons. Number 1 is prepare for the unexpected. That is, we think, you know, where we have the 3-year plan and the 5-year plan. And when you're in medical school, of course, you're kind of on autopilot to get through. But then you have to plan what you're going to do afterward. And what I've found is that the most wonderful things happen that I never anticipated. And these would include things like, while I was in the Navy, I got stationed in a place that allowed me to get a PhD. And so the whole philosophy life was not something that I expected, but it happened. MGH neurosurgery, I'm not going to go into the story, but the fact that I got into MGH neurosurgery was partly because of my philosophy stuff. And that obviously changed my life hugely because, as I'll show you in a moment, that institution, like Bao Tip, had the idea, it wanted to get people to increase knowledge in the world, to add to new knowledge. I did not ask for the chair at Brigham and Children's and the Harvard professor. It was something that I was nominated for, and so it was something that kind of came out of the blue, and obviously was a very important change in my life. One of the most important international events was a Blue Voyage that I did with Neshmetin, and Churka was very much, Professor Dean Kilich was very much part of that as well in 2004, and that was a remarkable experience, and it made me, among other things, absolutely fall in love with Turkey. But it also taught the importance of international friendships, which for me then led to becoming the president of the World Federation, which again was something that I didn't particularly see. And then, of course, today, that is this Medal of Honor. I mean, who would have predicted a year ago that I would be here? And yet it's a wonderful honor which is completely unexpected. And so I would say that one thing that one can do instead of trying to make sure you have the perfect plan, because those perfect plans always get foiled, is number 1, cultivate acceptance of the world as it is. That is, things change, the world is the world, life is life, and sometimes you just have to roll with that. But then secondly, this idea of being grateful for what you do have. That is, yes, you have the exams and you're worried about the exams as a student, but you're at a great university, you're going to be doctors, and that's something that most of the world can't even come close to. So I think that being grateful as a point of view, as a life position, has been really important for me. And just to say a couple of the unexpected twists, I mean, one is this, my musical stuff, which turned out to make me love to do things with my hands, which led me this is a shield for a music competition as a young guy, made me want to do things with my hands, made me want to be a surgeon. My family, I think very subtly, but definitely said, you know, you better do something good with your life. And so my sister, who is a neurologist in Toronto, just received the Order of Canada, which is a very major event there. This sister's a doctor, this sister is a wonderful opera singer. My father was a doctor, so the family you're born into is something that you don't have much control of, but it can be very important. The Navy time, as I say, got my philosophy going. And then Frank Yoles, being at the Brigham when I moved over there, just changed my life completely. Lesson 2, I think, is care. Learn to be empathetic. And that is not only, it's for your patients, but for others, including your family and for yourself. And let me just talk about that for a minute, because I think for me, it's been extremely important to listen to patients, to respect their life and culture, which may not be your life and culture, but you have to realize that you have to try to adopt your thinking to them. To know that the team is the important thing. That is, a solo doctor now, not much interest, because you have to work with teams. You have to learn to work with teams. Don't be distracted by the stuff like insurances and quality assurance problems and electronic records. Your job as a doctor is to take care of your patient and keep that as your focus, and you won't worry too much about these other things. And then avoiding complacency or arrogance. That is, anybody who's a good doctor, I think, wants to be a good scientist, but also is humble. Because your patients keep you humble. I mean, you don't know everything. And sometimes you make mistakes, and so you must avoid thinking that you're God as a doctor. Secondly, and very, very important, I've spent a long time talking with the students about this this week, care for your family and friends. That is, the people who I know who are the happiest people toward the ends of their life are people who have maintained friendships. And that's one of the reasons, for example, that blue voyage was so important for me and for Catherine, for my family. And so the family can be, you know, your biological family, your social family, your work family, and the world family. This is our children. We had 4 children under the age, grandchildren of mine, under the age of 1, within 1 year. And so this was a naming ceremony for the children. This is the children and their friends. And obviously my own sons here, and then my sister and her ward. So caring for your family. And then something we usually forget completely, and that is caring for ourselves as doctors. That is not getting completely exhausted, not becoming depressed, but understanding what makes you happy. And there are some websites that can help. The Greater Good Science Center, which you can get on the website, the Values in Action, Signature Strengths of the University of Pennsylvania. And most of all, evaluate how you deal with stress and failure. Do you do that in a way that allows you to survive? Most of the people I know who deal with this do it by talking with other people, by having close friends who they can be absolutely frank with. But you need to, I think, try to make sure that you have that kind of ability, because resilience is something, as a med doctor, I think I needed very much, because sometimes things don't go the way you expect. So, care always, try to cure, and that's where a university like BioTip becomes important. Because, yes, you need to be an expert in your field, but I think then research is important too. And so, an expert in your field means lifelong learning, it means mentors who you continue to deal with, it means going to meetings nationally and internationally so you know what the field is doing, and contribute to treating disease is very important. But then advancing knowledge. And that's where you all come in. Because I think the model that is being created here is a model like Harvard or MIT, a model of trying to train people to move fields forward. And it could be in different areas. It could be in clinical research. It could be translational. My imaging research would be considered translational, I think, with brain mapping and image-guided neurosurgery. Or it can be basic, and you can decide what you want to do. But there's a very broad range of possibilities for doing research. And my institutional homes all had that as sort of the mantra. So the Harvard Medical School is a research institution. It believes in moving things forward as well as teaching. The MGH, the Brigham Children's Hospital, Dana-Farber Cancer Institute, are all dedicated to creating new knowledge. And so growing up in that environment, I think that it just naturally comes out of your need to take good care of patients to want to do those things. The history of innovation at the place where I was included Harvey Cushing, who had the nerve to think you could actually operate in the brain, and nobody had done that safely before him. There were a few people that had done surgery of patients that died and not had good results. He made it possible to do. Ingram and Matson did the same thing with pediatric neurosurgery. And Ingram is that's why I'm the Frank Ingram Professor, because he was the first pediatric neurosurgeon, and the chair at Harvard was named after him. The first Linac radiosurgery was done at the Brigham, the first MRI-graded craniotomy and focused ultrasound. And then teaching as well. And teaching doesn't have to be in medical school. You can teach nurses, other people. You can teach patients. You can teach people about sexual diseases, other diseases. You can teach any place. You can teach in the local society, in meetings, everywhere around. And what I've found is that the international options, many of the pictures that you saw in my portfolio, or pictures of being abroad, because it's been just a wonderful, wonderful career to be able to teach around the world. And not everybody will want to do that. But I can tell you that if you don't teach around the world, teach locally, teach nurses, teach anyone you want about medicine, because it's an important field. So in summary, I'd say the 3 suggestions that I would have: prepare for the unexpected, because I can guarantee you there are going to be unexpected events in your life. Learn to deal with them. Care intensely. I love the fact that Dean Kilic said he wanted to speak Turkish because that's what comes from the heart. It's the wanting to make sure things go well, and then trying to cure, and that's the thing that distinguishes all of us in this room. That is, through our teaching, through our research, through our commitment to new knowledge, we're trying to cure. And so I think I'm extremely honored to get this medal. It's a wonderful thing to have, especially wonderful to be able to see all of you here, to be able to see my mentor, that is Neshmet Amir, the Vice Provost, who I share Georgetown with, obviously Dean Kilic. And all I would say is thank you and good luck.
Sahneye davet ediyorum. Buyurun hocam.
And this time I was going to talk in English. And to continue to live the spirit of today, we decided to give Professor Black's name to our molecular neurosurgeon lab. And we promised that every year we're going to come up with several researchers lab. This is our best present to you, I think. Thank you so much for being here.
Evet, törenimizin sonuna geliyoruz yavaş yavaş. Ama önce Black sınıfı öğrencilerini sahneye bir fotoğraf almak üzere davet ediyorum. I'd like to invite all of the Black class students to the stage, please, for a picture with Professor Black. And then after that, I'm going to invite all of you, our guests, onto the stage for a picture. They've spent the last few days on boat tours, at a museum. They've been asking Dr. Black their questions, everything they wanted to talk about. Bütün öğrencilerimiz bol bol sohbet etme fırsatı buldular. Özellikle Black sınıfı, Profesör Black'le. Hazır mıyız? Nasılız? Thank you very much. Herhalde herkesin güldüğü bir resim çıkar bütün bu resimlerden. Thank you very much to the Blacks class. Now I'd like to invite all of our students to the stage and our faculty members, of course, for a picture. And thank you very much for coming today. Geldiğiniz için çok teşekkür ederiz. Son fotoğraflar için sahneye buyurun lütfen. Teşekkür ederiz. İyi akşamlar.